I think this conference is sort of an evolutionary year. We see the introduction of ustekinumab into clinical practice for ulcerative colitis, so that's a kind of a landmark thing. We have been watching subcutaneous vedolizumab, which I anticipate will be approved sometime in the early part of next year. So switching from intravenous induction to subcutaneous maintenance of vedolizumab is very interesting. Earlier this year, the Varsity trial was published comparing adalimumab versus vedolizumab in patients with ulcerative colitis, and at this meeting we saw some data about histology for that outcome measure as well. So once again, seeing that it's possible to get not only endoscopic remission but histologic remission in patients with ulcerative colitis, and that looked to be a bit more robust with vedolizumab. There'll be a presentation tomorrow looking at the deep venous thrombosis and pulmonary embolism rates in patients with ulcerative colitis treated with tofacitinib. And what we saw was during the placebo-controlled portion of that trial that all of the DVTs and PEs occurred in patients who were receiving placebo, not tofacitinib. Then when you got into the long-term extension, you could see some cases of DVT and PE, but at a lower rate than what was observed in a recent trial in patients with older patients with rheumatoid arthritis who had cardiovascular risk factors. So I think given the recent FDA labeling changes for tofacitinib for ulcerative colitis, we've been thoughtful and cautious about how to use it, but these data do suggest that the DVT and PE risk in patients with inflammatory bowel disease, and ulcerative colitis specifically, may not be as high as in that high-risk rheumatoid arthritis population.